All right, you're stuck with me for case review, I'm sorry. If we're doing pacemakers and ICDs, remember back in your paramedic class and some of your education, you looked at a strip, you saw pacemaker spikes go, let's go to the hospital, right? This one we're kind of going to go a little bit more in depth so we're taking care of our patients appropriately and that we can recognize what might be going wrong with our pacemaker patients, rather than just recognizing their strips. So our objectives for today, we're going to explore the early developments and recent advances in the pacemaker and ICD. There's been some new things come about with them, and we'll need to be aware of because they're pending FDA approval, so we'll start seeing this technology in the United States here, I'd say, within a few years. We'll look at the underlying conditions that warrant pacemaker and ICD placement. A healthy person does not require a pacemaker, so we'll look at what sort of medical problems may occur that our patients will have. They won't know, they won't tell us, but at least we'll be aware of it as pre-hospital providers. And finally, we'll look at normal, abnormal EKGs for our pacemaker patients to kind of talk a little bit about a criteria called Sgarbosa's criteria that's been around since 1996, maybe increase our suspicion of an AMI. So why is this important to us? Well, in 2009, which is the most recent statistics I could get, 62 pacemakers were implanted per 100,000 people. We have over 100,000 people in Lubbock. In fact, we have about 229,000 people in the city alone. They're getting older, our population is increasing, so we're going to see more and more pacemaker patients within our city, within our EMS encounters. There's a little history to pacing the heart. It isn't something that came out 20 years ago. This isn't new. Back in the mid to late 1800s, they discovered that if you applied electricity to a cat's heart, the heart stops. I mean, a revelation right there. I feel sorry for the cat. Then they also found that if you applied just a small amount of current to the heart, you could actually get the heart to contract. So it was tailoring it. They thought this was interesting, good bar information, didn't do a whole lot with it for a few decades. Now, the earliest pacemaker was this hand crank device right there. It was a big needle, went straight into the chest to pace the heart. And this was developed by a cardiologist and his brother in New York. As I said, they didn't do anything about, learning about what electricity does to the heart. And so we get to about 1940s, 1950s. They were having cardiac surgery that was actually successful. These post-cardiac patients still had this weak heart that needed some support. And so they started working with pacemaker technology. It was a lot like we do with our external pacing. You have an adhesive pad, electrodes, and they shocked externally. The units, and I don't have a picture of it, but the units were big, they were on wheels, you plugged it into an AC outlet, mobility was limited to as far long as your extension cord would let you go. They found out, though, that with a power failure, the device didn't work, and so these patients could die from that, particularly involving a child. And so they developed these battery-powered pacemakers. And that's about 1950s when they started developing silicon transistors to where it could lower the size. So the first pacemakers were pretty bulky, they governed our life. 1958, the weight of a pacemaker was 73 grams. Again, they were trying to make them more durable over the years. We didn't start seeing some big advances in pacemakers such as cardiac defibrillation until the 70s and 80s. Being able to pace, depending on the patient's need for a particular rate. If they were sleeping, they need one rate. If they were active, they need another. I guess working towards lighter weight cans. So 1995, 14 grams for a standard pacemaker. Anybody know what 15 grams, 3 nickels. So if you hold 3 nickels in your hand, that's the weight of a pacemaker in 1995. Of course, they've gotten lighter since then. Now today, we have pacemakers that weigh 2 grams. That's 2 paper clips. They don't even have wires coming out of them. They're currently in Europe. We're not going to see those for a few years in the United States. They're undergoing trials right now waiting for FDA approval. And the photo there to the left is a leadless pacemaker. It is inserted into the right ventricle, sits down there at the bottom. It's anchored at one end, and it paces the heart. Now, depending on the type of dysrhythmia the patient has, they'll either have a pacemaker that paces the atrium, one of the ventricles, atrium and one of the ventricles, both ventricles. It depends on what their needs are. Your pacemakers will have anything from 1 to 3 wires, and they can also include an internal cardiac defibrillator. So this is what's called a CRT, or a dual ventricular pacemaker. Number 1, there's a pulse generator. This is where your battery, your circuitry is, your wires come out. This is a 3-lead pacemaker. Number 2 represents a right atrial lead. This is where one of your leads is implanted in the right atrium, and it paces that atria. Number 3 is your right ventricular lead. It sits at the apex, or the bottom of the right ventricle, and it paces and senses at that point. And then the 3rd lead in this particular pacemaker goes through the coronary sinus, through the vessel, and is usually attached to the lateral left ventricular wall, and that will help pace the left ventricle if that's needed. Now, not every patient needs 3 wires run into their heart to pace their heart. Again, you get the pacemaker depending on the patient's conditions and their needs. Now, who needs a pacemaker? Typically, your bradycardic patients where medication, ablation therapy, any other surgical interventions would not be an option. Your second-degree type 2 AV blocks, not something that you just happen to have one night, but that's going to be ongoing and persistent for this patient. Sinus arrest, any sort of sinus node dysfunction, atrial fibrillation, the SA node is not firing properly, or your third-degree AV block. They may also benefit patients who have a daytime heart rate of 40 beats per minute, even with minimal symptoms, or those who have chronotropic incompetence. These are your patients where their heart rate is not increasing for their needs. So they sit up really quick and they pass out, their heart didn't increase its rate in response to them sitting up or standing up. If they can't be fixed by medication, they start looking at pacemakers if this becomes a chronic problem. So the first pacemaker we're going to talk about is the single chamber. This is one chamber. This is the simplest one you're ever going to see. It has only one wire coming out of the pacemaker. And in this case, it's implanted to fire at the right ventricle, at the apex of the right ventricle. It's going to pace the heart from there. You can also have pacemakers with one lead that go into the atrium. And this is an example of that. You don't see a whole lot of these in the United States anymore. These are more common in Brazil, some in Europe. Atrial pacemaking has been replaced in the United States mostly by an atrial ventricular pacemaker instead. But you may find a patient that does have this, usually used for atrial fib or sick sinus syndrome. And all it's going to do is pace the atrium. They have to have a good AV node and bundle branch, and the whole rest of the conduction system has to be working properly to be able to use this pacemaker. Now these are more common. We'll see these in the United States. Single chamber ventricular pacemaker. Again, it's a single chamber, so one lead, one wire, comes out of the pacemaker, and it's implanted at the bottom of the right ventricle, and that's all it senses and paces, the right ventricle. So it's relying on the atrium to do what it needs to do. But for some reason we're having problems electrically at the ventricles, and it paces at that point. Now, it doesn't require the atria and the SA node to be working 100%, so you can use this in permanent atrial fibrillation. You can use this in some of your AV blocks, but this isn't the best choice now. Now we go to 2 wires. This is better for your AV blocks. It maintains synchrony between the atria and the ventricle. If the atria is not firing right or the ventricle is not firing right, it can respond, it senses, it paces, it does what it needs to do to keep the heart contracting properly. These are dual chamber pacemakers. It means 2 chambers, 2 wires. But this isn't quite the perfect solution yet, because this isn't going to work well for your severe heart patients. You've taken care of the right atrium, you've taken care of the right ventricle, but the heart failure is usually on the left ventricle, and we're not doing anything for that. So as you can see from here, it's firing both in the right atrium and the right ventricle. It maintains that synchrony for somebody with AV block, but doesn't do a thing for the left ventricle. And they found out that if you just use a right ventricular pacemaker in these patients, the ones with heart failure, you're actually making their condition worse over time. So we needed another solution, and so they'll add another wire. So cardiac resynchronization therapy, which is also called CRT, or a dual ventricular pacemaker, has 3 wires. One goes to the right atrium, one goes to the right ventricle, and the third one goes through the coronary sinus and is implanted to the lateral or posterolateral wall of the left ventricle to pace the left ventricle. This is a video of just a heart. If those not familiar with heart failure, kind of shows you what's going on. So this is a healthy heart. This is your left ventricle. And now they're going to illustrate heart failure, left heart failure. So you're not going to get the contractility you need. The muscle is large, overdeveloped. The blood pours in there, but they just can't get all that blood out with every contraction because the muscle is very stiff, the walls are very thick, you're not contracting well. This is usually measured in ejection fraction, EF, your heart failure patients. And this is showing the CRT as it paces. And what it's trying to do is it's trying to get that left ventricle to depolarize about the same time as the right ventricle instead of just dragging behind because that muscle is so stiff and the walls are so thick and it just can't keep up. It's weak, so it's trying its best to get it to keep up with pacing. And the most common causes of left systolic heart failure, as we all know, having a heart attack. You've got a lot of fibrosis, scar tissue in the ventricle. Less common disease to the valves, heart valves, congenital causes, or simply getting older, or prolonged strain of the ventricle from years of high blood pressure. These are your congestive heart failure patients. These are the ones that have the fluid in their lungs, the ones that have the fluid in their legs, all the edema. They can't go walk half a block without pooping out. They are the ones that are going to benefit the most from having a third lead to get that left ventricle in sync with the right ventricle and increase your cardiac output. About 1/3 of your symptomatic heart failure patients have ventricular asynchrony, and that's where those two ventricles just are not depolarizing about the same time. This is an echocardiogram. On the left side, the patient has a CRT pacemaker, but it's been turned off. On the right side, it's been turned on. Now your left ventricle is actually on the right itself, but if you look at the two, and it will slow down here in just a few seconds. If you look at the two, it's almost chaotic, whereas resynchronization is off. You're not getting a good uniform squeeze in the ventricle. You can even see the valves look a little sloppy when it's been turned off, whereas on the on side, it seems like you get a little bit more squeeze. The valve is closing and opening predictably. So again, why is this all important to us? Because we're not cardiologists. Because we need to look at those ECGs. We need to understand what's going on with our patients. We're going to get some information based on our understanding of pacemakers, how to treat them better. You know, why is your pacemaker patient having trouble breathing? Why do they have weakness, chest pain? First of all, as a medical history, we all had the patient in the family. I just got a pacemaker. I've got no other problems. I mean, I don't have the diabetes. I don't have any other heart problems. My doctor said I needed a pacemaker, and I got a pacemaker. And we've all been there. And so if you have an understanding of how sick that heart is, do they have a 3-lead pacemaker? Probably got CHF. If they've got a single-lead pacemaker, maybe their SA node is not functioning right. So it helps us get an understanding of their history where they may be lacking. So we can look at it, we say, is a pacemaker not working right? You know, they're not 100%. Are they having an MI? Are they having symptoms because their pacemaker is doing exactly what it's supposed to do, and that's ramping up really fast to take care of VTAC? So going to the ECG, this is our single chamber atrial paced rhythm. Pacemaker spike, and it can be tall or small, only the height is only dependent on whether it's a unipolar lead or a bipolar lead and how far it is away from pacing site. It can be any height, that doesn't matter at all. But we're going to have an atrial paced pacemaker is going to have a spike right before the P wave. It's what creates the P wave. If it's not before the P wave, it's not working correctly. Pacemaker spikes are with the yellow arrows. Now normally it's upright if the lead is put into the right atrium, but you may see an inverted P wave in your inferior leads if it's placed through the coronary sinus, and that's perfectly normal. That's nothing to worry about. There's a P wave that was created by the atrial spike. This is your ventricular paced rhythm. We've all seen this. Wide QRS complex. Pacemaker spike is right before. There's no space between that complex and the pacemaker spike. There's your spikes there. If it's not wide, it's probably not working right. This is the wide QRS complex for the basics are not familiar with the ECGs. This is a dual chamber paced rhythm. This is the one that has the lead in the right atrium and the right ventricle. You see two pacemaker spikes. So the atrial one, you've got to have a bit of a P wave there. And then on this next rhythm, you see the ventricular spike and also your wide QRS that follows. And so it's pacing both the atria and the right ventricle. So this patient's probably got an AV node problem. This is the 3-wired one. This is the cardiac repolarization therapy pacing. And this is ugly, but this is doing exactly what it's supposed to do. You'll see pacemaker spikes where they're warranted. You notice that the second and the third complex have atrial and dual ventricular spikes, but then you go to the fourth one and you're missing that atrial spike. It doesn't need it, so it's not going to pace it. It senses and it paces. So there's your P wave that's created by the atrial spike. There's your two ventricular spikes, both your right and your left ventricle. And there's that wide QRS complex that says, yeah, I've got capture. Pacemaker problems, I'm sorry, I'm a Ford girl. But they aren't perfect. 911 is called. Some of the more common problems we get is failure to capture, failure to pace, undersensing, pacemaker-mediated tachycardia. All right, failure to capture, we'll see this at times. The red circle shows where the single chamber ventricular pacemaker is firing, but you're not getting a QRS complex following it. It fires, but nothing happens. It's not capturing the QRS complex. You'll feel the pulse, you'll feel it skip. You're not going to feel anything come through. You will never feel the pacemaker spikes. This is failure to pace. So the pacemaker in this case is not seeing a need to pace. It's just kicking along saying, oh, you know, hey, he's bradycardic, but I don't need to do anything. I mean, I don't detect it. So that wide complex follows the red circle because there's no spike, nothing pacing. So what you're seeing after that is the patient's own intrinsic rhythm. If you had the pacemaker turned off, that ugly ventricular escape beat is his normal rhythm. This is why you needed the pacemaker. Undersensing. The pacemaker is basically ignoring anything that the heart is doing. So on the atrial lead pacing, you notice that the pacemaker spike is after the P wave. It didn't create it. FP wave is the patient's own heart rhythm. And on the right side, you notice that the pacemaker spikes are the yellow arrows. They're kind of all over the place. They're not immediately followed by a QRS complex. The patient's own heart rhythm is what's creating the strips you see right there. The pacemaker is not doing anything to contribute. Pacemaker-mediated tachycardia. This is where usually a PVC creates a re-entry rhythm, and it goes back up to the AV node, and it creates a little circus rhythm. And the pacemaker sensing a need to pace based on that re-entry circuit, so it goes ahead and paces, and then comes right, shoots right back up. It's in a circular rhythm. And the good thing about the pacemakers today is they have an upper limit. They're not going to pace any faster than their upper limit that's programmed to them. So in this case, 110 beats per minute. So it's not going to go and do an SVT type rhythm of its pacing. It's going to stop at 110. So while not immediately life-threatening to our patients, if we recognize what's going on, we have a pacemaker that's going at 110 beats per minute, we can probably assume that we have pacemaker-mediated tachycardia. And, you know, this is not a 29-to-1 call, obviously. It's not going to kill them, but this is not something healthy for somebody with a weak heart, like congestive heart failure, to maintain that kind of rate for any period of time. So they do need to go as possible, particularly if you have somebody that's possibly an end code and saying, you know, I don't need to go. This is one reason to go. Demand pacemakers. So you have a patient with a pacemaker, you're not seeing any spikes at all, and you're like, is it broke? Demand pacemakers are most common programming. You're not going to see pacemaker spikes unless their heart rate drops below the program limit, like 60 beats per minute, 50 beats per minute, whatever the cardiologist is programmed in. So it's perfectly fine. If they have a pacemaker, you're not seeing spikes, and their rate is a sinus rate, no worries, they're doing fine. In this case, the pacemaker is kicking in whenever the heart rate starts to slow. It becomes a little bit bradycardia. A couple spikes come in with blue arrows, gets that rate back up, and then leaves the patient alone. And that's what demand pacemakers are supposed to do. I'm going to talk a little bit about left bundle branch blocks because they look a lot like a pacemaker rhythm. They look weird. You have to have a P wave before it. T wave may be inverted, and that may be normal for a left bundle branch block or a pacemaker. And they do look very similar. So this is a normal heart, no pacemaker. Just anybody out in this audience except for maybe Hal. Sorry, Hal. So from the SA node, the depolarization wave goes across both atria, stops at the AV node, just gets slowed down a little bit, continues down through the bundle pis, the bundle branches out to the Purkinje fibers, and then your ventricles fire and squeeze from the bottom up. For a pacemaker patient, or even one with left bundle branch block, here's your pacemaker lead, is going to the right ventricle. You have a pulse. Now what happens is your right ventricle, since it's right there, it depolarizes pretty quickly, pretty easily, but you don't have anything on the left ventricle. And so it slowly, cell by cell, depolarizes until the whole heart's depolarized. That's why you have the wide QRS complex. It's a whole lot slower to go from myocyte to myocyte to depolarize into the Purkinje fibers. So you're looking at ECG on the left side. It's a patient with a narrow complex rhythm. This is your normal folks, except for Hal. And then you have your bundle branch block to the right side. It's over 120 milliseconds. It's one of the criteria. Your left bundle branch block is going to have this R wave, this very prominent R wave in V6 and V1. And then you see that on the right ECG, while the right one is a normal person. Inverted T waves can be normal. It just depends on whether the terminal wave is upright or if it's negative. It's normal if you have opposing what goes up should go down type of mentality. If you're looking at V1, let's say that left strip over there, it's typically going to be very negative in your left bundle branch patients, and so you expect your T wave normally to be upright. Whereas if you go to V6, where it's positively deflected, your R wave, you need to have that T wave going the opposite way. If your T wave and your R wave are positive, you can possibly consider an injury pattern starting, particularly if they're complaining of chest pain. It's not normal. So a right ventricular pacemaker does look a lot like a left bundle branch block. You're going to have those negative deflected in the V1 and V2. You're going to have your upright R waves in lead 1, but V6 can go either way. The complex is going to be 120 milliseconds or wider, and you will have a P wave before QRS complex involved. All right, so there's an old wives' tale that says you can't tell if pacemakers having AMI, acute myocardial infarction. That's not totally true. We have ways of increasing your suspicion that they are having a heart attack. In 1996, Dr. Elena Sgarbossa and her colleagues published a set of criteria known as the Sgarbossa criteria for pacemaker patients and left bundle branch blocks with a higher suspicion of acute coronary syndrome. And it's been refined over the years by Dr. Smith and others based on a scoring system. Again, it's not a tell-all. This patient is absolutely having an MI or he's not, but it can increase your suspicion for it. So it's another tool in your toolbox. So there's 3 criteria. The first criteria may be uncommon. You really don't see this, but if it exists, it really could suggest an MI. And it's just like if we're looking at an MI for any of our other patients. ST elevation in a positively deflected lead, if it's greater than 1 millimeter, particularly if it's in 2 consecutive leads, increase your suspicion. So that kind of looks like any other patient we have, right? Second criteria, remember it's not all of these, it can be one or the other. In this case, ST segment depression in your leads V1, V2, or V3. These are your right-sided precordial leads. That's not normal in the left bundle branch block. Usually they tend to kind of ST elevation versus ST depression. So if you start seeing that, be suspicious. And the third criteria, this is lead V1, but if you have 5 millimeters or greater of ST elevation, be very suspicious that you may have AMI in progress. Now you are going to have some ST segment elevation in your right precordial leads. It's normal with a bundle branch block, but not at 5 millimeters. So as far as the scoring system is concerned, if you have meet any one of these, increase your suspicion for an MI, get that aspirin on board, get the nitro unless otherwise contraindicated. All right. Anybody want to take a guess at what you see here? I'll pick on Trey. Because you're right there. What do you see?
AMI.
Okay. AMI, yeah. You've got ST segment elevation, lead 1. You've got those big, greater than 5 millimeter elevation in V3, V2. And this guy's having a nasty one. Okay, this strip is from one of our reports. This is a patient that doesn't have a pacemaker for the left bundle branch block. If you look in V2, you notice that the T wave is pointing down, it's inverted, but he also has an S wave, that's his terminal wave. That shouldn't be there. That T wave should be upright. So does he have an MI? Who knows? But if he's complaining of chest pain, I'm going to increase my suspicion for it. This is another strip. If you look at the lateral leads, V5, V6, T wave is either flat or again it's going in the same direction as the terminal, the S wave. And if you also look at AVL, another one of your lateral leads, that T wave is basically flat. This ECG, this is a pacemaker. It's kind of hard to see the pacemaker spikes, but notice that they're very small. Kind of have to look closely on your strips to see them sometimes. All right, so internal cardiac defibrillators. They're not a separate device from a pacemaker. These recent ones are just integrated in with the pacemaker, so you have one little puck. The latest implanted ICDs will analyze the ECG, will record it, defibrillate as needed. It can even do a short amount of time of pacing after defibrillation. They typically deliver about 40 joules of energy. They don't need as much as we deliver because it doesn't have all the skin, subcutaneous muscle to go through. So normally the patients are instructed by their cardiologist, don't call EMS if it defibrillates once. I mean, let it do its thing. If you feel fine afterwards, continue on. That's what it's there for. But they will call EMS if it happens several times or if their symptoms don't subside. Again, that increases the importance of increased suspicion of what's going on with these patients. If they have illicit drug use, they have SVT, atrial fibrillation, that all kind of contributes to multiple shocks. If you need to, you use your ACLS protocol. We don't have any medications or contraindicated for pacemaker patients. If they need the amiodarone, you give them amiodarone. ICDs may have an overdrive function that will detect ventricular tachycardia. And so you see on this 12-lead strip, the patient starts off in ventricular tachycardia on the very left, and time continues to move to the right. So you notice his pacemaker kicks in about the time that you see V2, V3, V1, and it rapidly paces. I mean, it's just trying to beat the speed of the ventricular tachycardia. And by doing that, they can stop and the patient converts back to their regular rhythm. The theory being that the fastest pacemaker, whether it's a cell in the heart or whether it's a mechanical device, wins. And so that's exactly what happened on this 12-lead. The ICD actually took the patient out of VTAC, not by shocking him, but by overdriving his pacing. Now we have new ICDs. These are available in the United States. My understanding is about 1,900 of them right now, so we're probably not going to see one flooded right now. But they're subcutaneous planted. They don't go through any vessels of the heart. There's no wires running through there causing clots, increasing the risk of infection. They're tunneled subcutaneously. So you have a puck placed subcutaneously that's your pulse generator right here. And then you have one lead that's buried subcutaneously. It goes up here. And so when it defibrillates, it goes from here to here. This is about 80 joules. So it's about twice as much as a regular defibrillator, implanted cardiac defibrillator. But you decrease your risk for infection because you don't, and decrease your risk for clots. You don't have wires running through your vessels. These are typically used for patients who can't handle infections very well. Your diabetics, your dialysis patients, let's say your cancer patients, somebody where you want to have a low risk for infection. It's also used for your younger people because it has less scarring. You're going to be stuck with a pacemaker for the rest of their life, so you want less scarring. Okay, so how do we treat our pacemaker patients? I mean, I've gone through a lot. You just treat them as any other patient. They have chest pain. Unless you have any other reason to suspect otherwise, consider it as cardiac. Look at their history. Again, you don't withhold any medication for pacemaker patients simply because they have the device. You treat them just as any other patient. But it is important to get the 12-lead. I will tell you, if you have a patient that is in a car wreck, possibly hit the steering wheel or the dashboard with his chest, you may want to go ahead and get that cardiac monitor on, even though it may be a 29-1 transport, because lead displacement, lead fracture is not really common, but it can occur and you want to recognize it. So you keep a cardiac monitor on and keep an eye on it. Again, medications are not contraindicated simply because they have a pacemaker. You can still externally pace, you can defibrillate with your pads, you can do CPR. It's just recommended to avoid placing it over the device, and in fact, an anterior-posterior placement is probably the best choice for these patients. That picture over there is a pacemaker that started eroding through the skin. I've seen one, and that's about it. It's more affected than that. That doesn't happen very often, but again, you do need to assess your patient if they have a pacemaker. Take a look, see what's going on down there. Pacemaker codes. Your patient may hand you a card that says, here's my pacemaker card. And you've got 5 characters of codes. You're like, I don't know what I'm supposed to do with that. As far as EMS and fire concerns, we just need to be worried about the ones that are paced and the ones that are sensed. So the A is atrium, V is ventricle, D is dual, so it means atrial and ventricle, and O or 0 is none. So we can look at that. Just look at your first 2 codes. They'll give you an idea what you expect to see on the ECG if the pacemaker is firing properly. All right, so we have one case report. This is kind of an interesting one. One of my stage shifters ran on a patient. EMS and fire department responded to an unresponsive female in the 30s who was found in bed with weak slow pulses, Kussmaul's respirations, and severe edema to all of her extremities. Abdomen was documented as a +4. Our family saw her last night, and added that she completes home dialysis daily, in other words, peritoneal dialysis. According to the crew, she was not hooked up to her dialysis machine at that time, and that's what one of them looks like, but the bags were sitting there, and they found her disconnected on patient contact. The history that was provided to EMS was diabetes, it's type 1, hypertension, and end-stage renal disease. They don't know about medications. The family was not a good resource. So the first assessment, the patient was unresponsive at the time, noted the edema, did do a body survey, kind of looked at the edema on the foot and lower legs. And so we went ahead and did a D-stick and rated as high, and if you know our glucometer, 600 is the upper limit, so it's higher than 600. They were unable to obtain a blood pressure. They did document the pulse at 48 a week. They did finally get a blood pressure, and even with that slow pulse, she was about 133 over 92. I'm having a hard time seeing it from this side. But they did have to assist her ventilations with the BVM. They put her on the cardiac monitor as the first thing they see. Kind of look at that and go, okay. Notice that T wave is kind of way out there. You have a small amplitude QRS complex. B wave is there. Not quite sure what's going on, but safe to say it's bradycardia. So according to Dr. Dillon, the cardiac monitor, QRS duration of 98 milliseconds, ventricular rate of 82 beats per minute. Field pulse, so you got 40. It did a double count. It took that T wave, and I thought it was another QRS complex that doubled. So be careful if your Zoll monitors and not doubling your rate on you. And a QTC of 619, that is very long. I don't know how accurate that is, since I couldn't seem to figure out what was a T wave or a QRS complex anyway. So Dr. Zoll goes and says demand pacemaker interpretation is based on intrinsic rhythm. In other words, it's looking at what's going on with the rhythm and thinks there's a pacemaker there. Continues on with a whole lot of other things because it doesn't know what's going on. This is the cleanest 12 lead we have on this patient. Now remember, she is a dialysis patient, although been doing her dialysis religiously, according to her family, like she's supposed to be. We notice over here that there are no pacemaker spikes, but we think Dr. Zoll is probably thinking those little blips. It's hard for you to see in the back. There's little blips on that line. Might have been what it thought was pacemaker spikes. I don't know. You do have kind of a left bundle branch type morphology to it. So again, maybe supports Dr. Zoll there thinking it was a paced rhythm. Look at those T waves. I should scream out hyperkalemia, right? Okay, very peaked. You don't want to sit on those. They're sharp at the top. They're tall. So pre-hospitally, they go ahead and get the high flow O2 on. She was 78% initially, so they got that taken care of. They're on a monitor, got an IV, Since family wasn't a very good historian, they went ahead and gave the Narcan, simply because of the respiratory difficulties. OPA, they tubed the patient, and the crew did a good job in saying, hey, let's give her back. You know, she's probably hyperkalemic. And they went ahead and continued with post-intubation, sedation, and analgesia. So here's a little bit of that report. They accommodate Norcron, and they intubated successfully on the first attempt with a 7.5. So this is the patient's hospital results. Blood glucose is 1,238 per blood. Huh?
Is that high?
Yeah, it's a little high. It's a little high. Blood gas, arterial pH is 6.734. So a little bit on the acidotic side, at least. Serum potassium, 8.0. So if they had given her acetylcholine, I don't think she would be with us today. Your normal is between 3.5 to 5 milliequivalents per liter. Her H&H was a little bit low too. She was 8 and 31. And there's your normals for females. She arrested twice in the ER. So got her back, secondary to hyperkalemia. She's diagnosed with diabetic ketoacidosis. You know, it's like no kidding. Respiratory acidosis or respiratory failure. She was extubated the next day, and a lower GI bleed with acute anemia. Has an additional history that family didn't know of CHF with an injection fraction of 30 to 34%. So her heart's not kicking out a lot of blood anyway on a normal day. Does anybody have any questions?
I'll talk loud. All right, good presentation on ICDs, pacemaker. I think the most important thing about a pacemaker, and Kim, I think you covered it pretty well, is what does it do to our management of the patient? Not a whole lot different, right? There's not medications that, oh, shoot, they have a pacemaker, so I can't give this or can't give that. Obviously, we need to know it's there. We need to know how it can change the EKG and what have you. But medication-wise, true treatment of the patient, it really doesn't change that much. The other thing I think to keep in mind is with the ICDs, we're seeing more and more of those, the implantable defibrillators. And you're right, I haven't seen the new style. I didn't even know those existed, that don't actually have the leads down in. But, you know, if you have a patient that was shocked a time or two and you get called, remember the device is probably doing what it's supposed to do. They went into VTAC, VFib, for some reason the machine sensed and shocked them. So, you know, we're gonna get our pads on and watch them. You know, if you see VTAC, VFib on your monitor, give it a few more seconds than normally whenever you would actually shock them. Probably their machine's going to shock them back out of it again. So we can shock externally, but that internal machine actually is probably doing a better job because it's intimately associated with the heart. I think it's 20, 30 seconds, or do you know? Like it has
It's actually less now, it's a 7 seconds.
7 seconds, even quicker. But so, you know, give it some time, let it try to do its thing. If it doesn't, then at some point, okay, let's charge and shock. Mentioned the broken leads, dead battery, which batteries we're not seeing as many issues with the new ones. You know, everybody's thinking, yeah, you see what you can do on your cell phone over 24 hours. This thing doesn't use much battery life. You see the broken leads on occasion. You usually get a chest x-ray if you're worried about it. You can actually literally see the wire and it'll just be broke. So it's kind of neat, first time to see that. I also want to mention the Saragossa criteria. That's a really controversial thing. If you ask like 10 cardiologists their opinion of it, you'll get like 15 different answers. So a lot of them say that's hogwash. We don't even pay attention to that. Other people, you'll call the cardiologist. So our first question, well, did they meet Saragossa criteria? Do they have a STEMI? So I don't really know the right answer to that. So there is something somebody developed that's really controversial on if it means that there's an acute MI or not. So that's all I got. Any particular questions about pacemakers? And yeah, the one that rode through the skin, I've seen just a couple of them. They're kind of nasty. You'll see just this chunk of metal hanging out. Usually they're folks that just didn't take care of themselves, and it's just kind of exposed. It's a chronic wound and draining pus or what have you. It's kind of weird to see that. Yeah. All right, cool. Continue on with question.